Good morning, ladies and gentlemen. And for the latecomers, as in JT, just get something to eat. And that's right. Please have breakfast and enjoy each other's company, and we'll get started while you're eating. I'm Ed Savitz, the current foundation president, and Georgios Romanos will be assuming that position forthcoming for the next year between now and our meeting in Washington, D.C. As you look around the room, we don't have the numbers of people here that we wish we had or should have. We envisioned our Titanium Society being at least 100 members, and as you can see, we're less than half of that. So we got another half of the room we could have filled up this morning. So between now and D.C., everybody think about it. Think about who you might want to invite, who might want to join the Titanium Society, and the monies that they pledge go to the foundation for the works that are done. And one of the things that we do is annually award the Titanium Society Brånemark Nobel Biocare Award. And today we are also honored in attendance with Professor Thomas Albrektsson, who was one of our past award recipients. And we're also honored all the way from Japan as Professor Komiyama has come. He has worked both with Kenji and PI extensively over the last 3+ to 4 decades. And Professor John Brunsky, who's been working with Kenji more closely for the past couple of decades or 3, and he's now, we finally got him to move out of the frozen tundra of RPI to Stanford. So we're glad. And as Giorgio says, he looks a lot better and healthier now that he's in the climate where, we're supposed to have sunshine outside, but luckily the weather gods shined on us last night, and we had our president's reception had over 1,000 people attend last night. So if any of you did get to go, I'm glad you went. And I bet you enjoyed yourself as well. So let's go forward. Put that there. The Osseointegration Foundation honors an individual every year who has had an impact and leadership role in research, education, and charitable causes in the field of implant dentistry. And we've had a number of very well-deserved candidates annually nominated, and we've had a daunting task to select one annually to be the award recipients. To this year's recipient is one of our founding fathers' giants in the field of osseointegration. And he's endeavored to advance the field ever since he in the form of continually evolving excellence, ad modum Brånemark, including from the original China bridge through Novum, and now he's perfected the trefoil technique. I did read at the opening ceremonies a number of the accomplishments that Kenji had over the years, and I'm sure all of you were there, so we don't have to bear repeating, and I don't want to burrow into Kenji's time to talk today. But that's what he's done, that's what he's accomplished, but that's not who Kenji really is. Those of us that have been blessed to get to know him back as far as the 1980s, we've learned that he's much more than those accomplishments. He has the mind that is of a brilliant and inquisitive scientist. He has the hands of a sculptor. He has the compassionate heart of a missionary, and he's going on a mission soon to Chile to operate and help people that couldn't afford it otherwise. And he's also got the faith of a disciple, and we know of whom's disciple he was with PI. And he has helped bring implant dentistry out of the field of the it works in my hands voodoo implantology to evidence-based science upon which implant dentistry today thankfully exists. Kenji, over the years, has made and designed and spent weeks at a time in training the rest of us that wanted to follow in his footsteps in PI, and he would take time out of his practice to do these types of things. And like I said, he's going to be traveling recently soon to come to Chile. And so without much, I had another video we're going to show, but it's going to show up in a more appropriate place. So we're going to, without any further discussion, introduce the award winner this year, Dr. Kenji Higuchi.
Good morning, everyone, and thank you, Ed, for that somewhat generous introduction. I can hardly wait to hear what I'm going to say now. It is my honor, and I'm humbled to stand in front of this very distinguished and committed group. You all are a special group that have made a commitment to some of the goals of the Osseointegration Foundation and the Academy. But it is an opportunity also for me to thank you personally for this very distinguished honor. When I was asked to speak and share a few moments with you and some thoughts on the some of the accomplishments and development of osseointegration, as well as what lies in the future, it didn't go unnoticed by me that this usually is something that is assigned to one who has been around for a long time. And when I looked at the list of 10 previous recipients of the Brånemark Osseointegration Award, I saw a resemblance more to Obi-Wan Kenobi than to Han Solo. So I guess the shoe fits, and so here I am. Anyway, thank you for showing up at this rather challenging hour. And what I'd like to do is just talk to you a little bit about some of the assigned topics I've been given, but in a very different way than what usually is presented at a scientific meeting. This is the 33rd annual meeting for the AO, and from the onset, the AO has focused on science, on ethics, as well as the clinical application of osseointegrated implant rehabilitation. Been very consistent about that and been a global leader in these areas. Whereas the foundation has focused on research, education, and charitable causes. So all of these fields of osseointegration, and that's how I like to term it, the field of osseointegration, have played a very important part of my career. Before I begin, however, I'd like to acknowledge several individuals that are present this morning. And without these individuals, I don't think I could be standing here. First, as Ed referred to, is my friend and colleague, Professor John Brunsky. I first met John in 1983, and John was requesting some of the original Brånemark implants from Gothenburg, from PI. And he was a little reluctant just to ship off a batch of implants to this unknown engineer. And through the advice of Thomas Albrechtsen, PI then designated me, who I had been in collaboration with for about a year, to travel to RPI and to be John's controller. So I had a vet John, and as a consequence of that, we had quite a number of years where we were doing animal studies on the early loading experiments. And since 2000, that relationship flourished, and we have continuously worked together on many different projects. And in 2007, we became partners in a consulting LLC called Osseoconception. But John follows in the legacy of Professor Richard Scaylock. And in my opinion, and I think an opinion shared by many, John is the premier biomedical engineer in the field of dental implants. And so John has been a tremendous source of information to all of us that practice, and he's been a personal anchor for me throughout my career. So, John, thanks a lot. The second individual I'd like to introduce to some of you is Professor Yataro Komiyama. I first met Komiyama Sensei in 1982 at my first visit to Gothenburg. And he was in the process of spending 3 years studying in the laboratories of Professor Brånemark and Thomas Albrechtsen. And in 1983, Dr. Komiyama took what he learned in 3 years in Gothenburg and introduced osseointegration to Japan and that part of the world. And he continues to be just a tireless ambassador for spreading the message of osseointegration through many continuing education courses, through groups that he's organized, and his clinic. He now is the director of the Brånemark Osseointegration Clinic in Tokyo. And in walking into his clinic, you would think that you were walking into a shrine, because as you walk into the door, there's this floor-to-ceiling photograph of Professor Brånemark. So he indeed is a brother of mine from a different mother, but we have the same father. Most importantly, like many of us that have demanding careers, without a incredible spouse, we could do nothing. And my wife Mary has really been, I get choked up talking about it, but she has just been my anchor, and really exhibiting just a world of patience, putting up with the genetic coding of a workaholic, and has really supported me through over many years. I believe it's on the upper right-hand side. We're in the photograph there. We're in Dublin in the receiving line for meeting the President of Ireland, Mary McLeish, and this was on the occasion of her being elected to an honorary membership in the Royal College of Surgeons of Ireland, and I was fortunate to be able to participate in that meeting. But Mary could reveal to many of you that even though you may see me around and heard me speak, I come across as fairly subdued. But Mary would tell you that I am actually doing invisible cartwheels. So anyway, I just, I couldn't be here without my wife. So thanks, Mary. In almost all cultures around the world, there has been a practice over the years before the written word of the oral tradition. And this is a means of which information, knowledge, ideas are passed from one generation to another by word of mouth. And in today's environment of peer-reviewed publications, there is a missing part of some of our culture that isn't passed on in the written world. And these are important ideas that are non-scientific, but they really impact how we perform our jobs and our responsibilities as doctors and as healthcare providers. So in the spirit of the oral tradition, I would like to share with you some of the culture that I have learned, much of it coming from PI, hopefully for some of you to be able to pass down to the next generation of clinicians. In North America, of course, all in this room, I think, are familiar with the fact that it began in the Toronto Conference in 1982 in May, where Professor George Zarb organized this landmark meeting in which osseointegration was introduced to all the heads of departments of prosthodontics and oral and maxillofacial surgery. This was a well-attended meeting, and it was a whirlwind exposure of science, long-term documentation from PI and his staff. So that happened to be in May. And in August 1982, the first international training course was held in Gothenburg. And by true blessing and serendipitous events, I was fortunate to attend this first training course. There were 3 American teams and a team from Belgium. And this is a photograph of PI standing, giving a series of lectures. We were there for almost 3 weeks. And I remember taking notes, and the note that I recorded was something he said that just struck me. He said that it's not how to handle the drill and screwdriver, it's how much the cell can take. And I thought, I've never heard any lecturer, any speaker, any prominent surgeon say something like that, and it just struck me as just being different. And so after 3 weeks coming home, I decided that I wanted to get involved with using fixtures to help edentulous patients. But what I didn't realize was that it hadn't been decided whether or not this modality would be released to those in private practice. I did have a background in full-time academics at the University of Iowa. However, at the time, I was just in private practice. And so there were individuals that were advising, please keep this in the university for the next 5 years. We can't let this out into that private practice world. But PI is PI, and so he decided that on his own, and he had a little chip on his shoulder from the academic community which had persecuted him when he first introduced the idea of a bone-anchored implant. So he just decided to come to the U.S. There were 3 American teams. One was in Washington, D.C., headed by Dr. Paul Krogh, who eventually became one of the early presidents of the AO. And that was in October 1982. Several months later, in February, he made his first of 13 trips to Spokane. We're a small city. We have our metropolitan area is generally estimated at about 600,000, but we're not a large city. We're not a huge university center in Spokane. We have a medical school, we have an extension dental school from the University of Washington, but at the time there wasn't a whole lot. But he decided to come, and on the first week of February we operated 5 edentulous lower jaws, and that's when our relationship began. And from that point on we struck a very strong bond in chemistry together, and I was then hopped on for the ride of my life. If you look at what was happening before with implants before Brånemark, it was very limited, and it was on the fringe of conventional dentistry. There was a very special conference that was held at Harvard University, the NIH Consensus Conference in 1978, headed by Len Schulman and Paul Schnittman. And at that time they talked about, they gathered people that had experience in implants. And they only studied 4 types of implants: a subperiosteal, transosteal, vitreous carbon, blade implants. And no mention was made of what we might consider an endosseous implant at that time. And basically the summary of the conference was there wasn't enough information except from individuals and anecdotal reports, and reports that it would be an effective treatment in my hands. In fact, there wasn't any scientific fact. And ironically, no mention was made of PI's work in a textbook that he published in 1977 with a 10-year experience. So this was omitted completely. But recall, this was a time before information was exchanged scientifically on the internet. So you would have to go to the library. And if you could find this was published in Sweden. So it was buried and not known. But no mention was made of this. So even after the Toronto Conference, 1982, a series of proclamations were made by the ADA and by the NIH, which also confirmed the reluctance of organized dentistry and government to be reluctant to accept the effectiveness of dental implants. And it wasn't until 1996 implants were not recommended as a part of routine clinical care in 1986, but 10 years later was the first provisionally accepted group of implants. And there were 2 categories: acceptance and provisionally accepted. And these were a limited number of manufacturers that had data in the U.S. that were what we would look at now relatively short term, 3-year and up to maybe 5-year data. It wasn't until 2004, now think about that, 2004, that was only 14 years ago that the ADA came out with a proclamation that they could recommend implants as for routine use. At that time, they emphasized that it was important for the clinician to realize this is a procedure where a device is placed for the lifetime of a patient. Specialty teams were also recommended to deliver this type of care. So 2004 wasn't that long ago. Especially for some of us in this room with gray hair, this was like yesterday. In the period of 1982 to 2014, in these 32 years, while all this was going on, PI presented revolutionary treatment concepts and devices that covered the spectrum of reconstructive surgery, not only in the oral cavity, but extended applications like in bone-anchored hearing aid for ENT application. The idea of a bone graft to the maxilla was unheard of before Brånemark. And it was like shocking to think that you could put implants in at the same time and have it end up with a predictable prosthesis in the maxilla. Orthopedic applications for limb replacement, hand surgery, finger and thumb replacement, rehabilitation of patients with rheumatoid arthritis were performed. Tackling the problems of the oncologic defects in a maxillectomy, facial resection, all these wide applications came from one individual, and that was PI. The idea of a zygoma fixture. I mean, think of that. The first zygoma fixture, I was around when we were first doing zygoma fixtures, and it was like, when he first proposed the idea, I thought, well, okay, let's, everything he has said seems to have a basis for it, and certainly now you look at today in the conference at the AO, it's assumed that this is a routine part of what we do. And if you look at the lower right-hand side, the number of implants have decreased because he very much valued keeping things minimized and simplified. So the spectrum of time in this relatively short period of time of 3 decades, and it wasn't that long ago. You know, the single tooth replacement. Now, that's the most common restoration today for implant rehabilitation. Single tooth replacement. The first one that had a prosthetic solution was only in 1982. That was the first one. So if you look at young clinicians today, they assume this has always been there. Well, it always wasn't there. We were doing pre-prosthetic surgery with skin grafting, bone grafting, floor of mouth procedures before osseointegration. So all this has happened within our lifetimes, which is, I mean, it's amazing and revolutionary. And what's happened with implants, there's been a global explosion of this clinical application. There have been now over 100 million patients treated since 1965, since Gösta Larsson received his first implants in the lower jaw. Nowadays, globally, over 10 million patients are treated with implants. 250,000 of those are those with edentulous jaws, as PI would say, the oral invalids. If you look at the demographics today, we're living in an aging society, so this need is not going away. In fact, it's increasing because with increasing age, there's increasing tooth loss. So we're seeing a whole new generation of population, a growing population that's increased over 50% in some parts of the world of those individuals over age 65 over the past 20 years. So all this has happened in a fairly short time span. If we look at the population of dentists in the world, there's over 1.7 million dentists, and only 16% presently are placing implants. But that's like 250,000 clinicians. If you project ahead, by 2020, that number is 30%. And who are these dentists that are doing this? It is the general dentists that are making up the largest group of users that place implants. So we're living in this world in which there's tremendous explosion. And if you go down to the exhibit area, you have seen the impact that osseointegration has had commercially in the manufacturing section. There's been over $4 billion of revenue, that's revenue, that has come in, estimated in the last 2 years. In the last year, is a $30 billion of patient billing and almost $10 billion of just the implant and prosthetic market by 2022. There's a projected compound annual growth rate of about 7% for the next 5 years. In 1999, on the occasion of his 70th birthday, PI made a statement, and it's one of the most profound statements that I think that I can pass on to you. He said, "The concept of osseointegration has developed into as much as a philosophy as it is as a technique for rehabilitation, a philosophy." So he would say things like this, and they kind of go unnoticed. But one of the reasons I think he and I had good connection was I thought about what he meant and what he said by philosophy. And this is the core of what I want to share with you this morning, is the philosophy of osseointegration. And in looking at it and explaining it to you, I have come up with 4 principal components which I think make up the Brånemark philosophy of osseointegration. First, the use of evidence-based treatment, multidisciplinary collaboration, healthcare ethics, and compassionate patient care. So these are all words. So how does this fit in to real life? How does it fit into our practice and into our professions? PI always focused on trying to make this a patient-centered with the patient being in the middle of the healthcare paradigm, we have the providers, there are researchers, and then there's industry. So what he was doing with these four principal components is he was trying to change our behavior. He wasn't just giving us components. He wasn't giving us devices. He wasn't teaching us how to place an implant, to do a bone graft, to install a zygoma fixture. He was trying to change how we act. And I suggest that perhaps this change in behavior is actually more significant than many of the wonderful devices and procedures that he has given us. He wanted to change our behavior. And so that's what I want to share with you. So, in today's world of 2 or 3 generations of new clinicians, the name Brånemark is not always that recognized, despite he's only been gone for a few years. And it's even more confusing what he stood for, because if you look at some of the early procedures, that's kind of what, if you see a high water bridge with showing a lot of titanium, that's like history, that's in the past, and it's not appreciated. And so that's kind of what he gets linked to. But what did he really stand for? What message did he want to leave us? And really, how does this apply in today's world? And I think that is part of what our responsibility is as senior clinicians experienced in osseointegration. We have to convey some of this information to this new generation. There is a saying, and there's a number of givens in life, and one of the most important givens that you have to accept is that everything changes and ends. Nothing stays the same. Nothing stays the same. And in 2016, I was asked by Peter Moy and Russell Nishimura to give a lecture at the AO in San Diego. And in that lecture, I pointed out that we're living in a very complex environment. We're practicing in a totally different world than existed 20 years ago, even 10 years ago. There are a lot of elements that make today's practice environment complex, and they affect the way that we practice. They affect the way we treat patients. But it's extremely complicated, and time doesn't permit to go through a discussion of all of these factors. However, I can say it's not your father's practice. If I make this slide 10 years from now, I wouldn't say not your father's practice, I'd say not your mother's practice. Because there are going to be more women than men practicing dentistry. So I've selected 3 what I call disruptors in this complex practice environment to note and to make an observations on. First being the impact of technology. Second, the economic pressures on the clinician and on the patient. And third, what I call an altered provider judgment and decision making. I think these 3 things have affected how we provide osseointegration services more than maybe anything else. Impact of technology. Let's talk about that just for a minute or two. We do know that technology, and I love technology. Believe me, I love technology. I support technology. It is the future. So it is a reality. We have to recognize and embrace it. However, we have to also understand that it's expensive to purchase, expensive to maintain, and at every year, basically, it changes. And if you don't have technology, it's hard to compete. Technology, expensive new technology favors larger groups. The solo practice, it becomes much more cost prohibitive to acquire the latest technology, which changes, like as the seasons change. However, it does provide the potential for improved quality of care, but almost always there's an involvement in increasing costs of treatment. Big observation that I have, there is the potential for overuse. It's like if you have the latest technology there and you just spent a lot of money to buy it, you want to use it. If you're going to use it, you're going to charge for it. And where's the end point on that is the patient. The patient's going to pay for it. And that's when we get into these economic pressures. I showed you a little bit of a slide on educational debt. That is tremendous pressure on the new graduates. With technology, you've got high overhead costs. Everybody wants a beautiful practice to work in, to have your patients treated in. As a result, there's a rising cost in the implant treatment. If you see at meetings like the AO and a lot of the top-level implant meetings, you'll see clinicians showing cases in which they will replace one tooth or maybe 2 or 3, 4 teeth in the aesthetic zone, and that may take 5, 6, 7, even up to 8 procedures to show that one case that is, and it's incredible. The results are incredible that we can do. But it also might cost the same as having a bilateral total hip joint replacement for one tooth. Now, to me, I have a hard time talking with my orthopedic surgeons about things like that. I've treated a number of his patients, and they common response is, well, I think I went into the wrong specialty. Because of economic pressures, sometimes more implants than necessary are placed. Sometimes, instead of considering the use of short implants, you go right to grafting. To save money, clinical shortcuts are often taken, in which I see more and more non-aseptic techniques being implemented. I've had a chance to move around a little bit in the last 3 or 4 years, and I've seen kind of an evolution of that. Substitution of third-part components, using different implant systems and components that haven't been validated, that don't have the quality, but they're less expensive. And most importantly, I think, is the failure to objectively present a full range of treatment alternatives based upon self-interest. We know when we communicate with patients, it's how we communicate with that patient that will steer or direct them to a certain treatment option. One has to be careful about that, because one of our responsibility is ethically to be honest and transparent. This area of altered provider judgment and decision making, time doesn't permit to talk in depth about this, but the example I used in San Diego was I'm seeing a lot of situations, and I've talked with a lot of young clinicians, and I've worked with a lot of my referral dentists, that every time a tooth comes out, even if it's uncertain if there's going to be an implant placed, the site gets grafted. And really the literature doesn't support that. Or every patient that has an immediate implant gets some sort of a grafting, some sort of a membrane, some sort of privet. By the time that we're finished, we're adding procedures, because, and it doesn't mean that these procedures are technically wrong, but are they right for the patient? And if we're dealing with patient's best interest, what we end up doing sometimes is putting our self-interest first, and that breaks the trust relationship in the doctor-patient relationship. So, let's go back to the 4 principal components that I proposed that Brånemark was trying to convey to us. And it may seem a little bit ostentatious to say, oh, well, PI was the instigator of the evidence-based practice. Probably not, but I believe he had a tremendous impact on that, because before osseointegration came, before he came with 15 years of documentation before he introduced osseointegration to North America. Recall, at that time, we didn't have information technology. We couldn't share information that well. So it was a digital advancements where we could exchange information that really brought us to this to the area of having the good scientific evidence and literature that we could apply in evidence-based practice. But he would say it would take 10 years of follow-up before safety and effectiveness could be proven. Now, if you look at that evidence-based practice diagram, it involves not only the literature and scientific documentation, but clinical expertise, and then the patient's wants and needs. What does a patient want? All that combines, because academic knowledge alone does not equate to clinical expertise, or it doesn't make up for what the patient wants. The second area that I believe PI really influenced us was to collaborate and communicate amongst each other, to be exposed to expertise in different disciplines. If we didn't have osseointegration, at least I can speak for myself, I would know. I work a lot with a lot of engineers. I work a lot with all the different specialties in dentistry. I work with basic scientists, with statisticians, a whole range of individual disciplines that get brought together. We can share knowledge and solve problems. We can talk about our complications. We can talk about our solutions. I also believe that doctors should train doctors, not have commercial companies be training us. But that requires this collaboration and communication. And if we have that, we can then push the envelope to innovate and develop and find new solutions. And an example of this is a group that we began meeting back in 1985, and it continued on through about 2005 was the last meeting we had, but it's called the Reunion Group. And if some of you in this audience look hard enough, you will find your picture in this group photo. It was taken at the Coeur d'Alene Resort in North Idaho. But this is a group of individuals brought together: surgeons, restorative dentists, engineers, people in research, those in academics, from industry, basic scientists, lab technicians, and then international clinicians, because individuals from different parts of the world have a different perspective on how we should treat patients. So, the bottom line is the whole is greater than the sum of its parts. We are stronger together when we communicate and we talk. When we're in our early training in medicine and in dentistry, we learn about the principles of healthcare ethics. We learn them, we say yes, we answer on the different board exams. To get a license, you have to acknowledge all these sort of things. But they're just words. And, who can argue with any of these? But it's the application of that. But all of these are based upon behavior and choice. And that's why I say behavior is so important. So if you have in this area of altered decision making, and you bring ethics into it, there's some questions that we might want to ask ourselves. Well, first, the first advice is follow the golden rule. And the question you might ask is, would you want your spouse, child, or grandparent to be treated in the manner that you're proposing? When is safe enough? Maybe it's not about just the procedure or the device. Maybe it's your expertise. Are you prepared to explain what you're about to do to a peer review board, to a judge, a jury, or on public television? What would a colleague whom you respect and admire in knowledge and clinical and ethical judgment do in the same situation? So these are modern day applications in plain talk on how ethics should be brought into what we do, but it's behavior. The fourth thing is compassion in patient care. And I dare say that sometimes you might hear a little reference to compassion, but compassion is not really spoken about much. You can define compassion as a deep awareness of and sympathy for another's suffering. And then the second part, and wanting to do something about it. So it's not just identifying and having pity, it's say you become motivated. And you see, this is one of the goals and focus areas for the foundation. And that's why I believe the foundation is so important. You want to act on how you feel. You don't just sit there and say, oh, I feel bad about this. No, you do something about it. And the best example I can give you of that, and what I learned from him, was from Professor Brånemark. The best example is in the times that we spent in Brazil. We began in 1992, and then, of course, he permanently relocated his institute and himself and Barbara to Bauru, giving up basically everything he had in Sweden, moving into what he called the jungle, and treated patients at no cost. And he and I were operated in 8 different countries, totally pro bono, on our own expense. And it never mattered how that this was happening this way. He fought so hard to help these patients. And so how can that not rub off on you? And so he walked the talk. So I say to you, if Leonardo da Vinci and Albert Schweitzer had a baby, it'd be PI. Albert Schweitzer, I know there might be some young people here, but he won the Nobel Peace Prize in 1952. He was an accomplished theologian, a musician, and he was a physician that started missionary work in Africa. But he won the Nobel Prize, and unfortunately, PI should have received that award. I'm going to give you 2 examples of what I mean about compassion in patient care, because I thought, well, here I'm just talking about words, and everybody likes to see about a patient. This is a patient that PI, myself, and David Harris treated at the Blackrock Clinic and Hospital in Dublin, Ireland in 1990s, 22 years old. He had this horrendous bilateral cleft defect. He actually had the anterior segment of his cleft was removed, and he had just a residual small bit of tissue left there, and this big cleft. This left him being reclusive. He was kept on the farm with his mother, didn't socially interact. And so PI sent me the records on him, and we didn't have CT scans and a lot of sophisticated imaging at that time. And he asked me, he said, well, he has got a very bad crossbite. He has a big fistula. He can't function. He has speech problems, and he has become totally reclusive and doesn't interact with anyone other than his mother. So after a lot of preparation thought, we went into the operating room with the idea of trying to close the cleft, bone graft, restore function, and perhaps, if we're lucky, to improve the occlusion. And believe me, a cleft is not that easy. This is not an easy case. And so PI sometimes I thought he had too much confidence in me. And so fortunately, I had a very strong background in orthodontic surgery. I had a lot of experience with that. So I had planned to do a modification of a Lefort 1, multiple segment Lefort 1, in conjunction with the bone grafting. And we took this large piece of bone from the hip, installed it, put in 2 implants. There was a little bit of a residual fistula that was subsequently enclosed, And this is the end result for this young man. 1991, he was eventually restored with a fixed implant bridge based upon the 2 implants that were totally within the bone graft. This allowed him then to come out of his reclusive life. He left the farm and eventually became married. And it's things like that that we recognize as healthcare providers, that we're, as PI would say, we're giving something to another being, another human being, in a way that you cannot, you can't do anything more than that. You give back somebody's life. A few years later, in 1992, when we made our first trip to Brazil, to Bauru, where we saw the most horrendous defects that I have ever seen, a lot of bad tertiary unrepaired clefts, oncologic defects, syndromic patients. This was one of the patients we treated. It's a lady that, this is her pre-operative and pre-condition photos from when she was in her late 40s, and then at age 51, the unexpected happened, and she had a very aggressive squamous carcinoma involving the anterior maxilla, the nasal region, causing resection of the upper lip, rhinectomy, and anterior maxillectomy. So we treated her at Centrino, which is a small cleft lip and palate hospital, the most active one in the world. They would do 6 operating rooms. They would do typically between 6 and 8 procedures a day, 5 days a week. And the patients would come from all over the country, all over South America. So PI, myself, Sherston Bergstrom, who was an anaplastologist from Gothenburg, and then later Marcelo Oliveira, who was a fantastic anaplastologist that I helped obtain his training at the University of Iowa, collaborated on this patient, and we have treated her in 1992, and in 2007, when we came back for a visit, we had a 15-year follow-up. This is the first, in 1994, the results that we achieved. This is one of the first zygoma fixtures, zygoma in the left maxilla. The implants in the lower jaw were provided by the local team. And this is the follow-up in 2007, and it was Ed Bedrosian, I think, was with us when we saw these patients, a number of patients for follow-up, but she has a 15-year follow-up, which is fairly extensive follow-up for this type of treatment. Okay, so what we've been talking about basically is a very specialized area of healthcare, but in all areas of healthcare and globally, there are 3 principles that need to be addressed, and this is what all countries are searching for: an improvement of quality, expanded access, and reduced costs. And PI understood this. He was a horrible businessman, by the way. He didn't know a whole lot about business. It's the only area that I would say he just let other people take care of it. But he understood that in order to deliver health care, you had to improve access. And so he thought about this a long time. And he came up with this idea of the China Bridge that many of you might be aware of. It was eventually became the Brånemark Novum. And why did he call it the China Bridge? Because he could imagine millions of individuals in China that could benefit from osseointegration. So he came up with the novum. But unfortunately, the novum had some design problems and limitations because of the lack of technology. So there were problems, and eventually with fracture, too much, not enough space, it was too bulky, and a lot of broken screws, a lot of misfits, so it was discontinued in 2007. But he kept asking me, even during the 1990s and into the 2000s, and even before he died, he kept saying, what about China? What about the people in China? And so I thought about it after from about 2011 to 2016, and then it inspired his inspiration was to do something and make it happen. And so that's where I was really encouraged to look at another solution, and it's what we've been working on for the last few years, and that's this trefoil concept. But it's the first performance documented pre-manufactured framework that allows adjustability to fit precisely on 3 implants. We combine that with an efficient clinical workflow, and this then provides this passive bridge, definitive bridge, passive fitting on the same day of surgery. But what that does is it extends accessibility because of financial less cost and less time to provide the treatment. So it should theoretically apply to more patients. This is an example of a patient that had failing dentition both in the maxilla and mandible, ill-fitting partial dentures, caries under the crowns, and he was treated then with 4 fixtures in the maxilla for a fixed implant bridge with an all-on-4 and 3 in the mandible, and that left 7 implants replacing 24 teeth. PI would say it minimize and simplify whenever possible.
The most important thing is that when you meet people, meet patients 10 years, 20 years after the initial treatment, and they still show you how important it was. That makes medical research worthwhile. There's no award in the world that could match that feeling.
So I'm going to leave you with just some final thoughts. One of my favorite human beings is that lived in our history was Mahatma Gandhi, and he had the saying, live as if you were to die tomorrow, learn as if you were to live forever. But along with knowledge must come wisdom, because wisdom is the right application of knowledge. So if you boil it down, practice the golden rule, act with wisdom, share your talents, and care for your patients. And with that, I thank you again for recognizing just a small example of trying to follow in PI's footsteps. And I appreciate you all getting up this rather early hour to be here this morning. So thank you again.